I want you to picture a Formula One driver for a second. It's race day. But before they ever climb into the cockpit, before the engine even turns over, they're sitting in the back of the garage, their eyes are closed, their hands are moving in the air, gripping an invisible steering wheel.
Right, they're driving the track in their mind. They're, shifting gears, feeling the G-force on turn 4, visualizing the overtaking maneuver.
Exactly. It's called mental rehearsal. And the data on this is actually pretty wild. It reinforces neural pathways almost as effectively as physically doing the thing. And that is exactly what we're doing today on this deep dive.
Yeah, usually we take a stack of articles and research papers and just pull out the insights for you. But today we are taking the RCEM guidelines, the NATSIPs, 8 safety standards, and some of the latest trauma papers, and we're building a simulator.
A mental simulator, specifically for a HALO event.
High acuity, low occurrence. The really scary stuff you don't see every shift, but, when you do see it, you have to get it right immediately.
So what's the mission today?
We are managing a tensioning hemothorax in a blunt trauma patient. And we're going to use a framework called PEDAL-LP, which stands for Physical, Environment, Task, Timing, Learning, Emotion, and Perspective. It's the gold standard for visualization in elite sports and performance psychology.
So here is the deal for you listening. If you're driving, obviously keep your eyes on the road, but let your mind drift into the scenario. If you're at the gym or doing dishes, lock in. You aren't observing today. You are the consultant or the senior registrar. You are running the room.
We're going to break this down into 4 parts: the trigger, the walkthrough, the reflection, and finally post-strain monitoring. Let's start with part 1, the trigger. We really need to set the environment.
Okay, set the scene for me. Where are we?
It is 03.00. It's Saturday night, or Sunday morning really, in a busy UK major trauma center. I want you to visualize the resus bay.
03.00 has a very specific feeling in a hospital, doesn't it? The general hum of the wards has died down, but resus is usually holding that weird, tense energy.
Exactly. Focus on the sensory details. The lighting is harsh, fluorescent. It reflects off the shiny surfaces of the trolleys. It's almost too bright for that time of night. What can you smell?
In a trauma bay at 3 a.m., probably stale alcohol.
Stale alcohol, definitely. But underneath that, there's that distinct metallic tang of fresh blood. Maybe the smell of wet raincoats from the paramedics who just wheeled the patient in. Yeah. It's a sensory assault.
And how am I feeling physically? Because that matters for the simulation, right?
It matters huge amounts. You need to feel the weight on your shoulders.
Yeah.
You've got the lead apron and the gown on, so you're hot. You're sweating slightly. Your legs are heavy because you've been on your feet for 7 hours straight.
But I assume I'm not sleepy right now.
No. That fatigue is being completely overruled by a sharp spike of adrenaline. Because you're looking at your patient.
Who is he?
Middle-aged male, unrestrained driver, high-speed collision. And he looks terrible. He has that translucent waxen pallor. He's clammy. He is actively trying to die right in front of you.
Okay, I'm in the room. I'm looking at the monitor. I'm looking at him. My heart rate is up. What's the first move?
We move into part 2, the walkthrough.
Okay.
We stick to the algorithm.
Yeah.
X, A, B, C, D, E.
Okay, X, exsanguinating hemorrhage. Do I see blood pouring onto the floor?
Let's say no. Yeah. The paramedics have wrapped him. There's no external spurting. Your X is clear.
Moving to A airway.
He's intubated. But here is your first tactile cue, and this is really important for the simulation to work. I want you to imagine you reach over to manual bag him while the ventilator is being set up. What do you feel?
Resistance.
Significant resistance. It's incredibly stiff. The lung compliance is just gone. That is a massive red flag. So you move to B, breathing. You look at the chest.
I'm looking for the classic signs, right? Distended neck veins.
Be careful there. In a textbook, yes. But this guy is a blunt trauma patient. He is bleeding internally. If he's hypovolemic, his neck veins might be flat as a pancake, even if he has a tension hemothorax.
That is such a great point. I think a lot of people get reassured by flat veins, like, oh, can't be tension, JVP is down.
Exactly. Do not fall for it. You listen, absent breath sounds on the right. You percuss, it's dull. Not hyperresonant like a pneumothorax, it's dull. That means fluid, that means blood.
And the vitals.
Dropping fast. BP is crashing, heart rate is climbing. He is in obstructive shock. This is the decision point. Do you send him to CT?
Well, if he's crashing, I can't roll him. He'll die in the scanner.
Correct. This is the fundamental difference between a stable and unstable patient. If he was stable, sure, get the scan. But he's not. The diagnosis is clinical. Tensioning hemothorax. You have to cut. Right now.
Okay, the decision is made. Immediate pleural decompression is indicated. My heart rate is probably 120 right now. I want to rush. I want to grab a scalpel immediately.
And that is exactly why you have to stop.
Stop! He's dying!
You stop for 10 seconds. This is the RCEM timeout.
Yeah.
It feels incredibly counterintuitive when the alarms are blaring, but you have to gain control of the room. If you rush, you make mistakes.
So what am I saying? Am I talking to the whole room?
Yes. You raise your voice just a little. You say, "Stop, everyone." This is John Doe. We are performing a right-sided chest drain for tension hemothorax. Do we have the kit? Does everyone agree?
And that prevents me from putting a knife into the wrong side, or even the wrong patient.
It happens. Wrong side surgery is a never event, but it still happens in the chaos. That pause locks the team in. You instruct an FY2 or a nurse to prep the drain while you identify landmarks. Okay, the team agrees. You've got your sterile gloves on, you've got the chlorhexidine. Now, where are you going?
The triangle of safety.
Visualize it on his chest. Anteriorly, the lateral border of the pectoralis major. Laterally, the anterior border of the latissimus dorsi. Superiorly, the base of the axilla. Inferiorly, the fifth intercostal space.
Okay, but let's be real. This is a middle-aged male patient. He might not be anatomically pristine. He might be carrying some weight. If I can't see those muscles clearly, how do I know I'm not going too low? I really don't want to put a tube in his liver.
That is a career-altering complication and a life-ending one for the patient. So advocate for the mid-arm point.
Walk me through that.
His arm is abducted. Lift it up. Look at the halfway point between his shoulder and his elbow. If you draw a horizontal line from that point straight across to the chest wall, it reliably lands right on the fifth intercostal space. It keeps you high enough to be safe from the liver or spleen, but low enough to drain the dependent blood.
That's a solid hack. Mid-arm point. Okay, I found my spot. I've prepped the skin. I've got the scalpel.
Make the incision. Transverse. About 3 to 4 centimeters.
That feels big. I usually see them made smaller.
It needs to be big. You need to fit your finger in there, not just the tube. You aren't doing keyhole surgery here. You are saving a life. Now put the knife down. Pick up the forceps, Spencer Wells or Roberts. This is the physical part of the pedal-up framework. I want you to imagine the resistance.
I'm pushing through the intercostal muscles.
Yes, but here's the critical safety tip. Hold the forceps near the tip. At the maximum depth you want to insert them. If you hold them way back at the handle and push hard, and suddenly you break through.
I plunge. I stab the lung.
Or the heart. Controlled pressure. You push, you spread, you push, you spread. You are going over the top of the rib to avoid the neurovascular bundle underneath. And then you feel that sudden give as you breach the parietal pleura. Stop. Drop the forceps.
Now the tube.
No, the finger.
Yeah.
Immediately. This is the finger thoracostomy.
So I'm sticking my finger into the hole I just made.
And this is the most visceral part of the simulation.
Yeah.
You will feel a rush. A gush of warm blood washing over your gloved hand. You might hear the hiss of air.
That's the decompression right there.
That is the life-saving move. For the crashing patient, the finger thoracostomy is the life-saving procedure. The chest tube just maintains the hole. So you sweep your finger 360 degrees inside the chest.
Yeah.
You're breaking down adhesions, confirming the lung is down, and making absolutely sure you're inside the chest cavity and not palpating the liver.
Okay, I'm in. The pressure is released. The anesthetist is shouting that the bagging is easier now. The BP is picking up. Now I need to get the plastic in slowly and deliberately to keep that hole open.
Let's talk hardware. What size tube did you ask for?
Well, there's been some debate on this lately. I know for pneumothorax, just air, we're going smaller and smaller. Tiny pigtail drains.
Right. For a stable pneumothorax, a small bore Seldinger drain is absolutely acceptable.
Can I use that here? It would be so much easier to put in.
In an unstable traumatic hemothorax, no. Current evidence and guidelines strongly advocate for the certainty of an open, large bore approach. We are talking 28 to 32 French.
Because of the blood clots.
Exactly. Blood from a trauma patient is sticky, it clots quickly, a tiny catheter will block in minutes. Then you're back to a tension hemothorax, but now you have a blocked tube giving you a false sense of security. Also, you need to monitor the exact volume of blood loss to know if he needs a thoracotomy. You can't assess that through a straw.
Okay, hand me the big drain. I've got the 32 French.
Wait, before you put it in, clamp the distal end with a second clamp.
Oh, good catch. If I put it in open...
You get a bloodbath. Blood spurting out over you, the floor, the bed. It's a biohazard, it's slippery, and it looks like you've completely lost control of the room. Clamp the distal end before you insert.
Done. Clamped. I'm guiding it in posteriorly and superiorly. It's in. Now, how do we keep it there? These big tubes are heavy, they love to fall out.
We advocate for the modified Joburg suture. It's the most secure way.
I've seen diagrams of this, and it looks like a Boy Scout knot tying exam. Can you visualize it for us simply?
Imagine a swing. You put a heavy suture through the skin next to the tube. You tie a knot, but not down at the skin. You tie it about 10 centimeters up in the air, so you have a loop of thread hanging there like a swing.
Okay, I see the swing.
Now take the long ends of that thread and wrap them firmly around the chest tube itself. Squeeze it tight, tight enough to actually indent the plastic of the tube. That mechanical grip is what stops it sliding out.
And if we have a Hollister tube attachment device?
Apply it. It adds a massive amount of extra security. But you don't stop there.
Taping it to the body.
Yes. You need to use an omentum tape, sometimes called the gate method, to secure the tube to the patient's aperture. This creates a loop. If the tube gets pulled during a transfer, it pulls the tape on his belly, not the stitches in his chest.
And check the connections.
The connection between the chest tube and the underwater seal tubing is the weakest link. Tape that joint securely. If that pops open, air gets sucked back into the chest and you've undone everything.
Okay. The tube is in, it's secured, we see blood draining into the bottle.
Now we move to part 3, the reflection. This is about perspective and non-technical skills. I want you to shift your mental camera, float up to the corner of the room, look down at yourself.
How did I do?
Be honest with yourself. Did you actually perform the NAT-SIPS timeout before the knife cut the skin? Or did the pressure make you skip it?
It's hard to stop when someone is dying. I feel like every second counts.
It is hard. But that's what separates the novice from the expert. Skipping it directly impacts your non-technical skill performance. And watching yourself from above, how was your communication? Was it clear and closed loop? Did you delegate effectively?
And looking at the patient factors, we used a large bore because he was crashing. But what if the scenario was slightly different?
Think about that. What if this patient was incredibly frail? Or what if you required immediate air transfer to a neurosurgical center? How might that alter your decision?
If he's going in a helicopter, I guess the stakes are even higher.
Exactly. If you put a small bore drain in a patient who is about to go up in an air ambulance and that tiny tube clots off mid-flight, you can fix that in the air. The anticipated need for air transfer would absolutely solidify your choice for a large bore. But for our guy today, unstable, bleeding, you absolutely made the right call.
We aren't done yet, though. The tube is in, but we need to talk about part 4.
The post-drain monitoring sequence. This is a critical addition. You cannot just high-five the team and walk away. The first hour of care is the danger zone.
What's the required schedule?
You must record observations every 15 minutes for the first hour, then hourly after that.
And what exactly am I looking for when I check the bottle?
3 things. First, swinging. The fluid level in the tube should oscillate up and down when he breathes. That proves the tube is patent and sitting correctly in the pleural space.
Second.
Bubbling. Is air continuously coming out? If it's bubbling like a jacuzzi, you might have a massive air leak or a bronchopleural fistula.
And third is output.
Precise volume output. This dictates the need for a thoracotomy. If he dumps a massive volume immediately or continues to bleed heavily over the next few hours, he needs a surgeon. You are the clock watcher now.
And one simple safety check regarding the underwater seal bottle itself.
Keep it below the patient's waist.
Yeah.
Always. If you lift that bottle up to move the bed, gravity works against you. The fluid flows back into the chest.
All right. The patient is stabilizing, the pressure is up, the drain is swinging, the bleeding has slowed. We can breathe.
You could open your eyes now.
That was intense. Even just visualizing it, you can feel the pressure.
That's the point of pedal ep. If you run this simulation, when the real thing happens at 3 a.m., your brain will say, I've already done this.
Before we wrap up, let's summarize the key learning points in reference to those pedal-eb domains. Let's start with decision-making and timing, the T's.
The big one is the reliance on XABCDE to prioritize exsanguination before the chest, but recognizing obstructive shock immediately. And that critical distinction between stable, where you get imaging, and unstable, which is a clinical diagnosis needing immediate intervention.
And technical skill and physicality, the P&T.
Use the mid-arm point as a reliable landmark. Remember, the finger thoracostomy is the actual decompression. Use controlled force with the forceps by holding them at depth. And securing is vital. Use the modified Joburg and take those connections.
Next is non-technical skills and leadership, the EMP.
Adherence to the RCEM timeout checklist, even under massive pressure. Calm, team leadership, and clear delegation.
Finally, let's touch on that size debate again to wrap it up. Large versus small bore.
Contrast the rationale. For hemothorax, large bore is the standard for unstable trauma to prevent clotting occlusion and allow accurate volume assessment. For isolated pneumothorax, small bore is perfectly acceptable.
And we should acknowledge emerging research on this.
Yes, studies like COMET-E2 suggest percutaneous small bore drains might be adequate for some hemothoraces. But we cannot advocate for that in unstable patients yet. Current evidence to change established practice just isn't there for the crashing patient.
So we've unpacked the procedure, the decision-making, and the safety checks.
So a lot to take in.
But before we go, we always like to leave you with a final provocative thought. We've spent this whole time talking about how to intervene.
But as emergency clinicians, we have a massive action bias. We love to fix things we love to do.
But sometimes the hardest move is to do nothing at all.
Exactly. When is the hardest decision not to put a drain in? Think about the 35-millimeter rule for a stable traumatic pneumothorax.
Sticking a tube in might actually cause more harm than good.
It introduces infection risk, causes pain, and keeps them in the hospital longer. For a stable patient with a pneumothorax less than 35 millimeters on CT, conservative management might be the best choice.
So are you brave enough to cut when they are dying? But also, are you brave enough not to cut when they are stable?
That is the real expert level.
That's it for this deep dive. Hopefully you feel a little more ready for that next 3 a.m. trauma call.
Keep visualizing, keep practicing.
See you next time.